Okay, let's talk about one of the most challenging but also one of the most important OSCE stations you're likely to face. We're diving into safeguarding, specifically looking at domestic violence during pregnancy. Getting this right isn't just about ticking boxes for your exam. It's about being the kind of doctor who can make a real life-saving difference.
Welcome to this clinical walkthrough on the domestic violence in pregnancy case for UKMLA, brought to you by Medi8, your 24/7 practice partner. We're here to help you get confident with these really complex scenarios.
So let's put you right in the picture. You're the FY2 doctor in a busy emergency department. Your next patient is a 30-year-old woman and she's pregnant. She's come in because of some vaginal bleeding, but as you're talking to her, you notice some bruises. Right there, that's the moment your safeguarding radar needs to ping, and ping loudly.
We're going to break this consultation down into 5 clear stages, pretty much exactly how you'd structure it in the real exam. First, the initial approach and building rapport. Then, how to even start talking about these sensitive concerns. After that, we'll cover the specific history you need to take, how to formulate a solid management plan, and finally, what to do for support and follow-up.
All right, let's kick off with stage 1, your initial approach and rapport. Honestly, those first 30 seconds can make or break the entire consultation. This is all about building a foundation of trust. Your opening line is so important. It needs to be warm, professional, and you've got to ask for consent. Look at that phrasing to make sure everything is okay with both you and your baby. That little detail is huge. It tells her you see her, not just the pregnancy. It's a tiny thing that builds a massive amount of trust. Now, before you even think about the bruises, you have to address why she came in. So, a great technique is to deliver any good clinical news first. It calms her most immediate fears. And then, you pause. Just be quiet for a moment. That silence is so powerful. It gives her a second to breathe, to process, and it shows you're actually paying attention to her as a person. Okay, now for the part that can feel really tricky. How do you pivot from the medical issue to the safeguarding concern? This transition has to be handled so carefully.
So, here's the big question, right? How on earth do you open that door to talk about her safety without making her feel attacked or causing her to just shut down? Well, the key is to have a structured, gentle, escalating approach.
The best way to think about this is like a funnel. You start really broad and soft with a gentle observation like, "I've noticed you seem a little quiet today." Then you narrow it a bit, linking back to the clinical reason she's here. After that, you gently address the physical sign, the bruises, and only after you've laid all that groundwork do you ask that direct safeguarding question. It's that gradual funnel that makes it feel safe.
And all the way through this process, you have to be reinforcing safety and confidentiality. A really direct statement like this is absolutely vital. You're literally creating a safe space with your words, and trust me, that reassurance can be the one thing that gives a patient the courage to speak up.
So, what happens if she's hesitant? What if she says something like, "I'm not allowed to talk about this"? Your job is to gently challenge that, while immediately doubling down on the safety aspect. Asking, "Who's not allowing you?" can be the key that unlocks the whole conversation. Showing her you're on her side. You're there to help, not to judge.
Okay, moving on to stage 3, she's disclosed. Now your job shifts to gathering a really systematic history so you can understand the full picture. First up, you need to explore the nature of the abuse. Use open-ended questions. You need to know, is it physical, emotional? Is there coercive control? How long has it been happening and how often? This is how you start to build a clear picture of the risk she's facing. Next, you need to understand her journey so far. Has she reached out for help before? What are the barriers she's facing? And this last question is absolutely critical. What would you like to see happen? This is patient-centered care. It's about empowering her and making her part of the solution. And finally, you've got to assess the wider impact. How is her mental health? Does she feel safe right now? Are there other children involved? And what about her support system, or maybe the lack of one? Knowing all this is essential for building a plan that will actually work for her. Look, knowing these questions is one thing, but actually asking them under pressure in an exam setting, that's a different skill entirely. It takes practice. So you can actually practice this exact case right now and get objective feedback on mymediate.com. It's a great way to build that muscle memory. Right. Stage 4, the management plan. You've gathered all this difficult information. Now your actions need to be clear, supportive, and above all, safe. This part is all about acknowledging her courage and then moving into decisive action.
Before you list a single option, you have to say something like this. This statement, it is so powerful. You're validating her experience, you are naming what's happening, and you are explicitly telling her it is not her fault. Please do not skip this step. It's a non-negotiable part of empowering your patient.
Your management plan needs to be crystal clear about what is a choice for the patient and what is your mandatory duty as a doctor. You can offer to admit her to the hospital as a safe place, but you have to respect your decision if she wants to go home. What's not optional, though, are the referrals to social services and discussing the case with a senior. And it's so important to frame social services as a support system, not a punishment.
And that brings us to our final stage, support and follow-up. Your job doesn't end when she walks out of the ED. You need to leave her with a robust safety net.
You've got to give her concrete, practical resources. It's not enough to just say help is out there. Give her specific names and numbers like the National Domestic Abuse Helpline. Explain practical things she can use like calling 999 and pressing 55 if she can't speak, or the Ask for ANI scheme at pharmacies. These are real, tangible lifelines.
So to wrap it all up for your exam, if the examiner asks how you reached your diagnosis, this is your answer. It's a combination of everything: the physical signs, the bruises, the behavioral cues, her quietness, and, most importantly, the direct disclosure that you made possible through your structured, empathetic, and completely non-judgmental questioning.
And I want to leave you with one final question to think about. We talk a lot about what to say, but are you prepared to manage the silence? That moment, that pause before a patient trusts you with their story, that can be the hardest part of the whole consultation. Your ability to just sit in that discomfort and hold that safe space for them, that's the mark of a truly great doctor.
Thinking about these things is the first step, but the next, crucial step is practice. You need to turn this knowledge into instinct so you can do it under pressure. The best way to do that is to practice this exact case, and you can do that right now on mymediate.com. It'll build the confidence you need, not just for the exam, but for your future patients.